Good afternoon. My name is Isabel Rohr. I'm the Deputy Director of the JDC Global Archives, and I'm delighted to welcome you to today's webinar in the context of the Bernard and Molly Storer JDC Archives Fellowship. I'd like to start by saying a few words about the JDC Archives. The JDC Archives holds the records of the American Jewish Joint Distribution Committee, also known as JDC or the Joint, which is the leading Jewish humanitarian organization. Our extensive collections are used by researchers from around the world, as well as filmmakers, journalists, family researchers, and others. We also offer fellowships to enable scholars to conduct research in the archives. One of these fellowships is the Bernard and Molly Storer JDC Archives Fellowship, which was established with a generous gift from Dr. Sorrell and Lauren Chassin to honor the grandparents of Sorrell Chassin. Sorrell Chassin is with us today. He will be introducing our speaker, Julia Schulte-Werning. But before he does that, I would like to introduce him. Sorrell and Lauren are supporters of JDC who have deep roots in the field of higher education and a long-time commitment to academic research and scholarship. Sorrell has dedicated his career to the advancement of higher education. He held several senior administrative positions during his tenure at the State University of New York at Albany from 1965 to 2013. Lauren Chassin has had a distinguished career in social work, and since her retirement, she has pursued her interest in art. I want to extend our thanks to Sorrell and Lauren who are with us for endowing this fellowship. A few housekeeping notes before Sorrell does his introduction. Julia Schulte-Werning will speak for about 45 minutes. This will be followed by 15 minutes of Q&A. Your microphones are muted, but you can send us questions at any time during the lecture. Sorrell, the floor is now yours.
Thank you. Julia Schulte-Werning has her bachelor's degree in modern and contemporary history from the Albert Ludwigs University in Freiburg, Germany, and a master's degree from the University of Vienna. She's currently a doctoral candidate at the University of Vienna as well. Her research interests are at the intersection of Jewish history, the history of humanitarianism, and the history of health and medicine. In her doctoral research, she examines the healthcare projects of Jewish humanitarian organizations for Moroccan Jews between the Holocaust and the decolonization. She received a fellowship from the Center for Jewish History in New York City and is the recipient now of the 2023-24 Bernard and Molly Storer JDC Archives Fellowship. Julia Schulte-Werning will now start her lecture.
Thank you so much for this kind introduction. I'm very honored to have received this fellowship this year that you endowed in honor of the memory of your grandparents. And before I start, I would also like to thank Isabel Rohr and Abra Korn for all their support in preparing this webinar and for their assistance over the course of the last year. It has been so great to work with the rich materials and records held at the JDC archives, and especially to see some of these materials in person in New York last fall. I'm actually also a bit overwhelmed that I'm now presenting as part of this webinar series because so many of the lectures that you have brought together here over the course of the past years have really been a source of inspiration for me over the course of my research and have accompanied me in my studies. So I'm very honored that I'm now invited to contribute to this. Tuberculosis is a bacterial lung infection that develops over complex stages. Weakened and malnourished persons are especially vulnerable to the disease, and its spread is facilitated by inadequate living conditions. In Morocco, where French colonial rule had fundamentally transformed the urban and rural spaces in the early 20th century, industrialization and urbanization led to overcrowded living conditions for the poor, and tuberculosis was a serious health threat to impoverished Muslim and Jewish families. In the late 1940s and 1950s, Jewish public health experts, physicians, and social workers sought to tackle this infectious disease among impoverished Jews. Their efforts were part of a broader medical program launched by the Jewish humanitarian organizations JDC and OZE shortly after World War II. The fight against tuberculosis revolved around case finding, treatment, and prevention, as well as rehabilitation. But there were many disagreements and challenges in finding the most feasible approaches. In the early 1950s, a sanatorium dedicated to Jewish patients was built in Ben Ahmed, southeast of Casablanca. This had started as a local initiative during World War II. And the Ben Ahmed Sanatorium project then developed into a joint undertaking by the JDC, by community committees, and the colonial administration. Drawing on records, this was too early. Drawing on records from the JDC archives and other archives, my presentation examines the sanatorium plans in the context of the JDC OZE healthcare program for Moroccan Jews. And this forms part of my PhD research, in which I am exploring how individual and collective responsibilities for the health of Moroccan Jews were negotiated and implemented from the late 1940s to the early 1960s, and what the evolution of Jewish medical aid might tell us about visions of Jewish futures in a post-Holocaust world marked by decolonization. To trace the idea of building a Jewish tuberculosis sanatorium means spanning a time frame of over 20 years. It takes us from pre-war Morocco to World War II and the Vichy regime, to the aftermath of the Holocaust, and to the turmoil of decolonization when Morocco gained its independence in 1956. And it takes us further into the 1960s, a time by which about 2/3 of Morocco's vibrant Jewish community had emigrated. So today I'm discussing preliminary findings and tentative conclusions. This is all very much still a work in progress. And when it comes to the sources, I would just briefly like to highlight that historical photographs, on the one hand, are invaluable sources for what I'm about to talk about, but they're also sensitive because scenes of poverty and of medical examinations show people in quite intimate and vulnerable situations. And we cannot always know in which context they gave their consent to be photographed in such settings. So I have decided to mostly reference photographs in the context of the publicity for which they were used for this presentation. A vibrant port city and an economic center of the French protectorate, Casablanca was home to Morocco's biggest Jewish community in the mid-20th century, with nearly 80,000 of Morocco's 250,000 Jews living there. While the more affluent members of the community lived in the newly built European quarters of the city, poorer families and those who had recently migrated from the countryside mostly resided in the Mellah, as the traditional Jewish quarters of Moroccan towns were called. In the French protectorate, welfare and healthcare were fragmented along the lines of the colonial population categories: European, Muslim, and Jewish or Israelite. As part of France's so-termed civilizing mission, medicine and hygiene were avenues of disciplining and modernizing the local population. Although the health of Europeans was a priority, over the course of the 1940s, the Protectorate administration expanded healthcare for the local population to counter anti-colonial mobilization against their rule, and I will come back to this point a bit later. In parallel, Muslim and Jewish organizations provided welfare for the poor, yet the capacities for non-European and impoverished populations were still precarious throughout the first half of the 20th century. On the slide, you can see an example from the 1930s, when the local Jewish aid society La Maternelle opened its polyclinic building in Casablanca to provide medical care for mothers and infants. And this building would eventually become OZE Morocco's biggest polyclinic. In 1939, very shortly before World War II, the Centre Anti-Tuberculeux Israélite was founded, headed by S.D. Lévy, a prominent figure in the reform landscape of Casablanca. But as soon as World War II started, many of these community projects had been halted, and instead emergency aid for the influx of Jewish refugees from Europe was at the forefront of the community work. Casablanca lawyer Hélène Kazé-Benatar, like Lévy, socialized in the Francophone world of the Alliance Israélite Universelle schools, founded a refugee aid committee and succeeded in drawing in JDC support. As Susan Gilson Miller highlights in her research, Overall, World War II, the influx of refugees and the collaboration with international aid organizations, quote, fundamentally transformed the attitude of Moroccan Jews towards their own future, instilling concepts like Moroccan Jewish rebirth through democratic reform and self-improvement. After the Allied landing in November 1942, the Vichy legislation was gradually revoked. While the relief for European refugees and survivors continued, the circle of Casablanca reformers worked to revive their aid for the local Jewish population, who were slowly recovering from the discriminatory Vichy legislation and the wartime rationing of food and other necessities. It was in this context that in July 1943, Kati announced that the committee was ready to resume its activities in the fight against tuberculosis amongst the poorer Jewish populations of Casablanca. Its president, Levy, sent out a call for membership amongst the Jewish community and presented a plan for building a sanatorium for Jewish children suffering from tuberculosis. It was to be built in Ben Ahmed, a small town 90 kilometers southeast of Casablanca, and that was supposed to offer a healthy climate to support recovery. On the slide, you can see a map where Ben Ahmed is located and also the blueprints of this early project. Throughout the first half of the 20th century, sanatoriums were indeed a staple in tuberculosis treatment and offered patients medical care, rest, and access to fresh air and sunlight. In its circular letter, Kati acknowledged that for such a, quote, large-scale project, the combined effort of the community committees, the Jewish population, and the protectorate might, quote, scarcely be enough. This call thus put a spotlight on the question of resources and responsibilities for the health and healthcare of Moroccan Jews between the formal community structures that existed, private donations, and the colonial state. It was in this period, when the war was still raging on in Europe and other parts of the world, that Moroccan Jewish reformers and community leaders started pushing for outside aid to resume their aid and welfare work that had been interrupted. The American JDC and the European-based OZE network were amongst the organizations they addressed. Yet in these war years and also in the immediate post-war years, OZE and JDC were deeply engaged in emergency aid for survivors in Europe and beyond, and could not spare many resources, although they indicated their overall interest in and sympathy for the Moroccan Jewish plight. This changed in the late 1940s. Alarmed by the upsurge of anti-Jewish violence and riots in Morocco and other parts of North Africa in the context of the creation of the State of Israel, international Jewish organizations started to intensify emergency relief for refugees and immigrants to the young state. The aid bifurcated into emergency aid for those communities which nearly all left, like in the case of Libya, and programs for the so-term settled population, where immigration was more of a long-term question, like in the case of Morocco. OZE Morocco and other OZE branches in North Africa began receiving major budgets from the JDC, and in the late 1940s became the body through which the JDC channeled most of its medical aid. On the slide, you can see some numbers of the early 1950s, giving an impression of the scope of these endeavors. The 1953 JDC annual report was quite fittingly titled The New Geography, and indeed showcased that by the early 1950s, this region figured prominently and sat quite naturally on the JDC's map of relief theaters. As the emergency aid in Europe that had characterized the immediate post-war years gradually toned down, and as Jewish relief in Soviet-ruled Eastern Europe had to close down, North Africa emerged as a major relief theater of Jewish aid. In view of the losses in the Holocaust, North African Jews were deemed the demographic reservoir of world Jewry and became a key focus of international Jewish organizations. Here it's also necessary to take a closer look at the political situation. After World War II, Moroccan Jews were drawn to competing political visions of the future. Vichy had betrayed the promise of French republicanism and fundamentally questioned the visions of emancipation fostered by the Alliance. And this in turn drew more and more to Zionism and a minority to Moroccan nationalism. As Emily Gottreich and Rachel Hackman point out in their research, pre-war ideological fluidity began to harden more and more and began to become mutually exclusive. As the Moroccan independence movement gained traction in the 1940s and early 1950s, and Pan-Arabism shaped the outlook of many anti-colonial activists, the place of Jews in the new Moroccan nation was an open question. And at the same time, thousands started emigrating to the young state of Israel, an operation also fostered by the Jewish Agency. Against this backdrop, international Jewish advocacy groups followed the events in North Africa with increasing alarm and regarded the erosion of French colonial power in North Africa as jeopardizing the safety of the Jewish communities living there, putting the right to emigration at the forefront of their advocacy over the course of the 1950s. Intertwined with the precarious legal status and these open questions of the future, the health state of Moroccan Jews was of major concern to local and international Jewish organizations. When a JDC and OZA delegation visited North Africa on a fact-finding mission in 1948, all observers and delegates emphasized the difficulty of obtaining reliable data on demography, mortality, and morbidity rates. The numbers and tables the delegates presented were based on incomplete state and community censuses and small-scale studies and estimates by local doctors. But it was clear that infectious diseases were prevalent and infant mortality was high in the overcrowded living conditions of the Melach. For the OZA and JDC workers, as for other Jewish organizations active in this setting, the Melach held a specific place in their map of Moroccan Jewry. It constituted a site of imminent endangerment of health and an impetus for engaging in modern intervention and medical improvement. As you can see on the slide, visual narratives played a crucial role in framing the Melach as a space of intervention. Here we can see two examples of how these images of poverty and destitution were used, but also rephrased and reframed to highlight the transformative power of medical aid. These images circulated widely between the respective actors and organizations, were used and reused for publicity purposes, and created an image of the Moroccan Jewish communities to be modernized and reformed through modern medicine and healthcare. Through healthcare, the JDC and OZA sought to prepare Moroccan Jews for a modern and productive life, be it in Morocco itself, in Israel, or elsewhere. The evolving medical program of OZA Morocco was shaped by the long trajectory of social medicine the OZA network had fostered since its inception, and the JDC's expertise in US public health and social work models. On the slide, you can see an examination scene that epitomizes this self-understanding and this outlook. OZA Morocco offered general medical consultations for children and preventive healthcare for expectant mothers and newborns, and healthcare workers conducted mass screenings and built up a school hygiene program. These medical services also served to facilitate immigration to Israel. Casablanca, where the continuous influx of internal and transit migrants kept the Jewish population relatively stable throughout the 1950s, was the center of OZA Morocco's activities, both in terms of the leadership structure and the scope of medical services and facilities. And also the JDC offices for Morocco were located in Casablanca. When reviewing the state of the social services in Morocco for the American Jewish Yearbook in 1956, Benatta, the lawyer and activist I had introduced before, stated that the OZA had become a, quote, veritable ministry of health for the Jews of Morocco, whose activities reached, quote, from the newborn baby to the grandfather. This comment sheds light on two challenges or important context for this medical program. Firstly, the highly ambiguous relationship to the colonial state. On the one hand, the protectorate could outsource some of its responsibilities for the health care of its colonial subjects to private organizations like these Jewish medical programs. But on the other hand, the JDC OZA program also had the potential to openly question the ability and willingness of the colonial state to actually care for its subjects, and something that was a highly political question in the context of the decolonization movements. Secondly, while this outlook of a health ministry for Jews in Morocco certainly constituted the self-professed standards of OZA Morocco's program, the various facilities and the concrete workflows were subject to continuous complaints about and debates about reform. It was especially difficult to find qualified medical staff, for example. And this would also mark the fight against tuberculosis. One of the persistent issues that the JDC and OZA were dealing with was infectious diseases. OZA and the JDC were especially engaged in fighting the eye disease trachoma, the scalp disease tinea, and the lung disease tuberculosis, often summarized as the 3T. as you can see on the slide here. Although initially concentrating on children, soon the whole family was to be incorporated into these campaigns. However, tuberculosis posed different challenges than the fight against tinea and trachoma. Whereas JDC workers expressed confidence that tinea and trachoma could be controlled or even eradicated over the course of a limited number of years, for tuberculosis, the picture looked quite different. The disease develops in complex stages, and the risk of reinfections or cross-infections amongst families who live in crowded housing is high. And in this context, there were not enough beds for hospital treatment and isolation. And even though the development of antibiotics promised a breakthrough in the tuberculosis treatment in the post-war years, administering these drugs needed close medical attention, and they were by no means available to everyone who might have needed them. In the late 1940s and early 1950s, tuberculosis was indeed widely acknowledged as a major health problem amongst poor Moroccans. Initially, the French Protectorate administration had been rather reluctant to acknowledge this issue. But at the end of World War II, new surveys brought the staggering tuberculosis rates to the fore, and the French administration began to address this as part of its welfare politics. This needs to be seen in the context of late colonial development politics, with which the French administration sought to appease the demands of the anti-colonial movement. In this context, Jewish tuberculosis patients had access to both state-run and community-based medical services and facilities. Public chest clinics often designated certain days of the week to adult European, Muslim, and Jewish patients. And at the same time, OSE polyclinics offered examinations and ambulant treatment for children, most of them led by physician Léon Benzacon. Additionally, a very limited number of beds for hospitalization and institutional care existed across French Morocco. Overall, amongst the JDC management level, it was often emphasized that comprehensive tuberculosis work was beyond the capacities of a private organization and rather belonged to the realm of the state. JDC country director William Bine raised the issue in his yearly report. I quote, "The tuberculosis problem in this country, both as handled by the government, indigenous, and foreign organizations, may be considered as a stepchild. TB is not only prevalent, but is widespread and spreading by the day, particularly in the overcrowded melas inhabited by the Jews." He pointed to the ongoing international vaccination campaign that was run by UNICEF and the WHO, and that was also vaccinating Moroccans, and to the government efforts to increase the number of sanatorium and hospital beds for the Moroccan Muslim and Jewish population. But, quote, "not even the surface crust of the problem has been scratched." Given the prevalence of the disease, despite this all-encompassing, rather bleak picture, in the early 1950s, the JDC sought to develop a more comprehensive anti-tuberculosis program by better coordinating the existing work. To this end, tuberculosis specialist Ladislau Molnar was sent to survey the conditions on the ground. Between 1951 and 1954, he traveled to Morocco 3 times. Molnar visited medical services and hospitals, consulted the local staff and the management level, as well as community bodies and state authorities, and converged these into surveys and recommendations for a systematic tuberculosis program. To Molnar, it was clear that the available infrastructure of medical facilities was inadequate for dealing with the high rates of tuberculosis among the Jewish population. And he advised the existent Jewish services to better coordinate their work and to function as advocates vis-à-vis the state. With this, he especially meant OSE Morocco and CATI, basically the only 2 major organizations active in tuberculosis care. CATI, the organization that had put forward the Ben Ahmed Sanatorium plans during World War II, as I mentioned before, supported tuberculosis-stricken families with material aid. And in Casablanca and Rabat, social workers of OSE Morocco and CATI also functioned as mediators between the Jewish services and the public institutions. Both OSE Morocco and CATI were subsidized and provided with medical equipment and foodstuffs by the JDC, which insisted on a clear-cut division of labor between the organizations, something that we often find in the history of the JDC. So working through existent or built-up organizations and then trying to bring this into a systemized program according to the vision of the JDC. Another issue that was closely connected was case finding, which actually went hand in hand with data production. Data on tuberculosis rates among the Jewish population was fragmentary, and the bleak picture Molnar had pieced together stemmed from a heterogeneous body of sources and statistics. Now, one attempt at a systematic case-finding campaign was made, although this had very mixed results. On the slide, you can see a photograph from a parallel mass trachoma project, a disease campaign that very much relied on mass screenings. This is a notable difference to the whole question of tuberculosis work, because overall, case finding was futile if there was no adequate follow-up for tuberculosis cases and no infrastructures to treat and isolate the patients. Furthermore, it was long clear that it would not suffice to only screen and treat the individual child or adult. Given the risk of reinfection, the whole family needed to be treated if sustainable results were to be obtained. As patients moved between services and facilities, it was crucial to improve the communication between the various institutions that took charge of Jewish tuberculosis cases. This gap between the vision of a systematized and centralized tuberculosis program and the actual state of the work was difficult to close. Molnar's recommendations and urgent calls for reorganization of late 1953 and early 1954 were increasingly met with exasperation from the side of the OSE and JDC staff on the ground, given the immensity of the problem, the staff shortage, and the strenuous negotiations with everyone involved. Although Molnar tried to calm the spirits and show that he had not lost touch with the local conditions, JDC Country Director Samuel Harbour answered to one of the reports that without an assigned physician, quote, any basic TB control program was an illusion. It cannot be done, exclamation mark. Harbour continuously urged the JDC and OSE headquarters to assist him in finding skilled staff, both for the tuberculosis program and beyond. Solving these issues became ever more urgent in the advent of a parallel project for Jewish tuberculosis patients that created an increasing momentum and pressure to solve these issues. The construction of the Sanatorium Israelite Ben Ahmed. As I said in the beginning, the idea of building a tuberculosis facility for Jewish patients in the small town of Ben Ahmed had been developed by Moroccan Jewish community activists shortly before the outbreak of World War II. In 1953, Kati's attempt to revive this project was a major point in drawing in American Jewish funding. Yet the mostly futile attempts of raising external funds and the rising construction costs forced Kati to abandon the project in the late 1940s, and they handed in the premises over to the French Department of Public Health, the Santé. The Santé took the funds and built a so-called preventorium for Moroccan children suffering from tuberculosis. The beds were split evenly between Jewish and Muslim patients, in acknowledgement of the funds provided by the Jewish community. Parallel to this, the Santé built a sanatorium in Ben Ahmed called Maison du Cure, and soon offering 150 beds for Moroccan tuberculosis patients. Here, the beds were split proportionally according to the population ratio between Muslims and Jews in Morocco, which was at the time the established practice of the colonial state and part of its overall group-focused population politics. Thus, the original Jewish initiative of Ben Ahmed had dissolved into the broader protectorate health program of the early 1950s. However, the visits of Molnar spurred a revival of the original Ben Ahmed project and brought together local Jewish community bodies, international Jewish organizations, and the state. When Molnar met with Santé director Georges Sicot as part of his survey in 1951, Sicot declined any possibility of augmenting the ratio of Jewish patients in the newly built Maison du Cure. Yet he suggested that the Jewish community could build an annex to the facility, a pavilion funded by the Jewish community, designated to Jewish patients and maintained as part of the Santé Maison du Cure of Ben Ahmed. So adding to these, or like being the third facility that would eventually be built in Ben Ahmed. The JDC, OSE Morocco, and community leaders met this proposal rather positively, not least because with this, more Jewish patients could be cared for, and in a separate building, kashrut could be observed, which was a major factor why many Jewish patients were actually reluctant to be hospitalized in general hospitals. As the project developed, the JDC bought 2 pieces of land neighboring the existing Maison du Cure of Ben Ahmed, and the new Jewish sanatorium was to be built. On the slide, you can see the architectural drawings for this project. The estimated costs of 20 million francs were split. 1/3 was to be covered by the JDC, 1/3 by the community council, and 1/3 was to be covered by additional fundraising amongst the Jewish communities of Morocco. Although, in fact, over the next years, the JDC share would steadily increase as the project progressed. And Benatar overall worked as a legal counsel for this project. For the Jewish community representatives, the evolution of the Sanatorium Israeli Ben Ahmed was a much welcomed opportunity to demonstrate that they partook in improving the health of Moroccan Jews. The local Jewish press actually frequently featured articles bemusing the welfare efforts. In 1950, a year before this project was started, the Zionist newspaper Noir had published a scathing critique of the tuberculosis work for Jews, calling out the community council and the government for doing too little, too slowly. Whereas individual doctors like Ben Zakhan were praised for their work, both the community bodies and the government were accused of not taking the situation serious enough. Here, the original Ben Ahmed plans of the 1940s were brought up as a symbol of the ineffective tuberculosis work. And the local Jewish organizations fared no better in this account and were criticizing for working in an unorderly fashion. Jewish welfare work was deemed both frantic and lethargic at the same time. This article echoed critiques JDC experts themselves frequently raised. The new sanatorium plans thus functioned as a way of reaffirming the role of the community council. As the construction was progressing in fall 1953, the time was ripe for wider scale publicity. In November, representatives and notables gathered at the building site and celebrated that the first cover plates had been installed. On the slide, you can see how this event made headlines in the community newspaper. To cover its share of the funds in February 1954, so a few months after this event, the Community Council launched a fundraising campaign calling for solidarity and unity. The head of the council underlined that the sanatorium was the fruit of concerted efforts. Ben Zakhan and a second local doctor toured through the Jewish communities of Morocco and gave lectures on the spread and treatment of tuberculosis and the envisioned role of Ben Ahmed in Moroccan Jewish tuberculosis control. Their talks were also disseminated in the press to reach an even wider audience. In his lecture, lung specialist Ben Zakhan drew attention to the misery in the Melach, where a vicious circle between cause and effect, between infection and reinfection, was at play, which to him evoked the conditions of the Nazi concentration camps. Describing the challenges of case finding and treatment given the limited ways in which patients could be isolated, the Sanatorium Israeli Ben Ahmed would function as both a curative and a preventive means in the fight against tuberculosis, he elaborated. With all these facilities, Ben Ahmed had become a, quote, true center of Moroccan health, as Ben Zakhan phrased it. Now also Jews will be inscribed into this space. In 1954, the work progressed to the satisfaction of all parties involved, and the JDC office in Casablanca sent photographs of the construction site to the headquarters, some of which I put on the slide here. Yet, although the conclusion of the construction work drew nearer, the procedure, how patients would be admitted to the sanatorium, was an open question and an important one. This put pressure on all involved groups because to use this new facility effectively, a procedure needed to be set up to determine which patients should be admitted to the care program in the first place. As discussed before in his surveys, Molnar repeatedly called for developing a systematic program and streamlining the existing services and actors. If it was already difficult to coordinate the services in a single town, like in Casablanca, how could Jewish tuberculosis cases across the whole country be monitored? This required a comprehensive overview of all Jewish tuberculosis cases, a protocol of care and treatment, and a coordinating body. All these elements were far out of reach in 1954. The recruitment of a tuberculosis specialist to the OSIS staff, which was a cornerstone of Molnar's proposal, was also equally fruitless so far. And who would have the authority to decide upon the cases? The selection of patients to be admitted to the Sanatorium Israeli was also a fight about the medical and political authority over Jewish health and who would speak on behalf of Moroccan Jews. What complicated matters further was that on an administrative level, despite public declarations, there existed no further written agreement on the details of the operating and maintenance responsibilities. On the slide, you can see one of SICO's official visits to an OSE facility, showcasing the necessity of a good working relationship and good publicity. As it was constantly pointed out in the reports, official speeches, and publicity statements, the French Santé was supposed to take over the maintenance costs, but there existed no tenable documentation, and the JDC urged the council to draw up an agreement with Santé Director SICO. And although a point since 1951, the land on which the sanatorium was built still belonged to the JDC as the original purchaser, and had not yet been transferred to the council as the body that was supposed to be running the sanatorium. Yet efforts to clarify the medical and administrative operation of the Jewish sanatorium were soon outpaced by political events and revealed the precarious timelines with which Jewish organizations operated in Morocco. Against the backdrop of political turmoil in the mid-1950s, when anti-colonial protests and violent confrontations mounted, the Ben Ahmed plan slipped more and more into the background. And as the dynamic of decolonization accelerated, time was running out to reach an agreement with the Santé. The JDC Paris office informed the Casablanca office that there were rumors that SICO was about to transfer to a new post in New York, and that SICO's successor, quote, would almost certainly be an Arab rather than a Frenchman. This rendered any new aid projects for the Jewish population uncertain, and made the conclusion of the operational details for already existing projects like this one all the more urgent. The dawn of Moroccan independence put the JDC operations into a fundamentally different time frame, making it important to create facts and establish precedents before the new government would take over. With independence drawing nearer, local and international Jewish bodies also became increasingly alarmed about the fate of those Jews living in small towns and villages. Although the Moroccan independence movement emphasized the joint struggle of Moroccan Muslims and Jews alike, events like the anti-Jewish massacre of Petit-Jean alarmed community leaders and advocates. When Haber met with the head of the Jewish communities in October 1955, as he reported in this letter you can see on the slide, he brought up the topic of Ben Ahmed only reluctantly, because this was, quote, almost ludicrous to him in view of the pessimism which pervaded my office during this conversation. The opening of the sanatorium seemed further outside of the realm of the possible than ever before. Given the isolated geographic position of Ben Ahmed, the head of the community council, quote, doubted very much whether any Jewish community would send patients to the institution under present circumstances, or for that matter, whether any Jews would be interested in going there. Although increasingly wary, the JDC was far from abandoning the project altogether and kept double-checking the formal guidelines for opening the sanatorium. However, the Sanatorium Israeli was open to Jewish patients at a moment in time when Jewish community leaders, aid workers, and international advocates wondered how to keep the Jewish inhabitants of these places safe at all. The remote geography had turned from a space of healing into a site of physical danger. Furthermore, Ben Ahmed's geography also held strategic value in the turmoil of decolonization. Since fall 1955, in fact, the premises were occupied by Moroccan auxiliary forces incorporated into the French army. Although the officer in charge assured the JDC that the occupation by these troops was to last a maximum of 6 months, the volatile political situation belied any such guarantees. And even though the other half of the sanatorium building was still empty, most agreed that, quote, it will be virtually impossible to fill the institution with Jewish patients because it is situated remotely and in a pocket of strong nationalistic feeling. As Morocco declared its independence from French and Spanish rule in spring 1956, the vision of creating a Jewish space of healing in the healthy climate of Ben Ahmed had clearly reached a dead end. On the slide, you see Moroccan and international headlines of OSE Dr. Ben Zakon's nomination as Minister of Post. He was the first Jewish member of the new government, and his nomination symbolized the integrative promise of a post-independence Morocco. JDC officials and Moroccan Jewish community leaders tried to navigate this new political landscape as best as they could, But again, the question who would speak and act on behalf of Moroccan Jews proved to be fraught. Throughout the early months of 1956, when all of this was shifting constantly, the JDC offices and community bodies debated intensely how to approach the new government about the issue. It was entirely unclear if the new government would respect the previous negotiations and understandings between the Community Council and French Santé Director Sicot. And the JDC offices were also worried about any political engagement on their behalf in their name, and therefore firmly put the responsibility for negotiating with the government with the local community. In rather tense meetings that followed suit with the head of the council and with Benatar, the new health minister's position emerged as follows. Either the sanatorium would remain with the Jewish bodies and institutions and be dedicated to Jewish patients only, then the sanatorium would receive no or only minor state support for its operating costs, in contrast to what had previously been agreed under French rule, or the premises were to be turned over to the state, opened both for Muslim and Jewish patients, and receive full government support. The question of the sanatorium's future owners, use, and funding extended beyond the small-scale institutional politics here. Whereas the French colonial administration had segregated medical services according to population categories, the new Moroccan government professed to abandon this so-called segregation and to offer all services to all Moroccans. This put into sharp relief the position of Jews in the new Moroccan nation. Would Jewish patients need or be entitled to their own facilities and services? How Jewish healthcare would inscribe itself in the Moroccan nation-building and state-building process was a contested question. Within the heterogeneous political affiliation amongst Moroccan Jews, for a brief moment, a joint Muslim-Jewish endeavor called Al-Wifaq emerged that advocated for Muslim-Jewish harmony and criticized the Community Council for its politics. In the Moroccan press, a prominent Al-Wifaq member directly attacked the Ben Ahmed plans and contrasted the image of a wave of Muslim-Jewish solidarity and unity with the supposedly counterproductive standing of Jewish organizations in this matter. For him, the Sanatorium Israeli Ben Ahmed was an example of misguided politics, and he urged to open the facility, quote, for the benefit of Moroccan patients without any distinctions. I quote again, that is the kind of gesture that the nation expects. Those are the actions that Jews conscious of their responsibilities towards the whole nation demand. On a micro level, the place of Jews in the Moroccan nation was therefore negotiated via this tuberculosis sanatorium building. Similar to the site of the sanatorium, other spaces of healthcare became equally charged. By the late 1950s, for example, the polyclinic waiting room was also becoming a symbol for intercommunal care. Whereas the fact that OSE facilities generally were open to all patients, Jewish or non-Jewish, had been frequently stated previous to independence, the issue of caring for Moroccan Muslim patients now assumed a new relevance. And OSE Morocco's president highlighted the changed domestic position of OSE. And he put an emphasis on the framework of the nation within which OSE Morocco's work was to be carried out. He also stated that despite limited capacities, quote, in our services, we see Muslims and Israelites sitting on the same bench and receiving identical care. A statement you can also see epitomized in this photograph and the caption. This emphasis on the Moroccan nation, on the responsibility for caring for its citizens, and the repeatedly stressed openness to receiving Muslim patients marked a shift in the rhetoric of local OSE representatives, testifying to the political pressure of demonstrating loyalty to the new state. And the waiting room was a spatialized symbol of this endeavor, as was the sanatorium. Indeed, in the late 1950s, many internationally operating Jewish organizations faced potential dissolution and liquidation by the Moroccan authorities. And these tensions show how Jewish organizations had to navigate the ever-shifting ground of being classified and categorized as national or foreign, as universal or particularized in the era of post-colonial nation building. The protracted issue of the dormant tuberculosis facility in Ben Ahmed only gained momentum again when the military announced its retreat from the premises 2 years later, in late 1958. The JDC had Benatar even draw up a retrospective lease agreement to demand compensation for the military's use of the premises. The question of the future use of the building was again at the forefront of these new negotiations. As the JDC was still the owner of the property, the Community Council pushed for a formal transfer of the premises to them. Within the Moroccan Jewish community, there was no unified opinion what was supposed to happen with the project, though, although the JDC stressed to evaluate all options and not to be rushed into anything. But still, it was unclear if Jewish tuberculosis patients would actually want to make use of the facility at all. Despite continuously raising this question, there was no feasible information on the patient's perspective in this case. Over the next years, the sanatorium building lay vacant, and several attempts to revive the discussions came to no fruition. Meanwhile, the overall JDC health program put an increased emphasis on staff training and health education in the realm of maternal and infant care, scenes of which you can see on the slide. This was a development in parallel to the tuberculosis work throughout the 1950s. Over the late 1950s, a family healthcare program was established, and furthermore, faced with large-scale immigration in the early 1960s, the program had to be adapted to new needs, like old age homes. Helping Jewish tuberculosis patients remained important, yet the sanatorium did not play a conceptual or logistical role in these plans anymore. The paper trail of the JDC correspondence on this protracted issue ends at some point in the 1960s, so I cannot say with certainty what became of the building, but it might be safe to assume that it was never used as a Jewish tuberculosis sanatorium. The idea of the Jewish TB Sanatorium Ben Ahmed brought together local community activists, Jewish public health experts, physicians, Moroccan Jewish patients, and colonial, then post-colonial state authorities in very fraught ways. On a macro level, these negotiations and the project development that spanned the course of 20 years shows the multifaceted transitions of decolonization in the realm of Moroccan Jewish health. If the accumulation of tuberculosis facilities in the town of Ben Ahmed indeed made it a space of Moroccan health, as Ben Lacan had phrased it in the early 1950s, then the place of Jews within Moroccan health was a liminal one. It was as contested as their place in the Moroccan nation. And for Jewish organizations, these shifts epitomized the open future of their work. Beyond immigration aid, these Jewish healthcare endeavors interlinked community development, welfare, medical humanitarianism, and relief in complex ways that shifted, just as the place of Jews in colonial, then post-colonial Morocco shifted. With this, I will conclude. Thank you again for your attention, and now I'm looking forward to hearing your questions and comments. Thank you.
Thank you, Julia, for a fascinating lecture. I will now open the floor to questions. So if you want to send us questions, please use the Q&A function on the Zoom, and I will read them to Julia, who will hopefully be able to respond to them. And as we wait for the first questions to come in, Julia, I have a question. So how did you come to this topic?
It's perhaps a bit of a longer story. So
tell us the longer story.
It mostly came through my MA thesis, where I was looking more on medical aid projects for Jewish communities in interwar Eastern Europe, actually. And then I kind of saw in some documents that organizations like OSE and the JDC actually had become active in North Africa after World War II. And for me, this opened all sorts of questions, because I saw some similarities in terms of how some of these projects and programs were set up. But I had so many new questions, which brought me to some of the questions I raised in this talk as well.
We got a few comments and a question. So one comment is from Michal Ben Yaakov, who herself was a fellow, and she's saying she always learns from your progress, and she's looking forward to the completion and publication. So are we. And the second question is, what have you found the most surprising about your research on this subject?
Perhaps the short answer is that everything is way more complicated than I ever imagined. This might also be true for other case studies and projects, of course, in historical research. But what fascinates me most is the way so many different actors, individuals, organizations came together in this work on working towards Moroccan Jewish healthcare. And some of these have very contradicting or conflicting political visions, but healthcare brought together many actors that perhaps otherwise would not have worked together. And this is, I think, where it might be interesting to look further into what made that possible.
And I know that you've used our archives. You've also used the archives of YIVO, and I assume, and I think from the photos, the archives of OSE as well. Have you used the French state archives as well to kind of, is there mention of the sanatorium in there as well?
So actually, I've been making use of some sources from this like French state perspective via the US Holocaust Memorial Museum, which hold some of the colonial records actually, and as like copies. And I'm also actually planning a research trip to France for next fall. But overall, you can trace the Ben Ahmed Sanatorium through some of the official publications on French tuberculosis work in Morocco, that's for sure.
That's interesting. That's very interesting. I don't see any more questions, Julia. I think it was so comprehensive that that people are not asking, but maybe the questions, if people send me questions after the webinar, I'm happy to share them with Julia if anyone has any question. Thank you again, Julia, and thank you to our participants for attending. The next JDC Archives program will take place on June 25th. We will screen the film, Cuba's Forgotten Jewels, a haven in Havana. This program is co-sponsored by the National Center for Jewish Film. The film screening will be followed by a Q&A with the film director and a mother who was a Jewish refugee in Cuba during the war. And you can register for the program via our JDC Archives Facebook page and also via our website. We hope that many of you will be able to join us, and please sign up for our e-newsletter if you want to be invited to our public programs. Thank you, everyone. Thank you, Julia. Good luck in your research. Oh, another person who is looking forward to your publication.